welcome everybody to the Henry Ford Transplant Institute Grand Rounds. Today's topic is updates in transplant pharmacotherapy, presented by our very own Mary Grace and Adina Popard. So our first speaker, Mary Grace Fitzmaurice, she completed her PharmD at the University of Pittsburgh and her PGY1 and PGY2 pharmacy residency at the Cleveland Clinic. After graduating residency, she's been a solid organ transplant clinical pharmacist at Henry Ford since 2020, working within all organ groups and pre and post transplant clinic. Her areas of interest include infectious disease complications within the solid organ transplant recipient, management of metabolic disease post-transplant, and the advancement of pharmacy education through precepting pharmacy learners and providing lectures within the Wayne State University. Adina Popard received both her Bachelor of Science and Doctor of Pharmacy degrees from Wayne State University. She completed her PGY1 pharmacy practice residency at Ascension St. John and her PGY2 at Henry Ford. After graduating, Adina stayed on as a solid organ transplant clinical pharmacist with us, and she's been working within all organ groups as well in the inpatient and ambulatory settings. Her areas of interest include optimizing solid organ transplant pharmacotherapy, evaluation of real-world outcomes associated with novel therapeutics, and safe transitions of care. I welcome them both and to present updates in transplant pharmacotherapy. Please put your questions in the chat box or feel free to ask.
Thank you so much, Dr. Pasher, for the very kind introduction. So today we will be discussing the implications of incorporating belatacept in maintenance immunosuppression regimens in the cardiothoracic organs for potentially renal sparing benefits. We will be reviewing updates in cytomegalovirus prophylaxis treatment and side effect management strategies, explore advances in the post-transplant metabolic management, and then assess current challenges in transplant care and discuss future direction. Now, although I wish I could stand here in front of you and tell you about all the new and exciting therapeutic advancements in the immunosuppression world, the truth is that since 2018, when Enfarsis, an extended release form of tacrolimus, gained FDA approval in kidney transplant recipients, there's been a paucity of new agents approved for this patient population. And although we have some new agents in the phase 1 and 2 investigational trials that we are hoping to see succeed, until then, we have been shuffling existing therapies in order to accommodate the growing needs of maintenance immunosuppression in patients with unique circumstances. We have often extrapolated from evidence in the kidney transplant group where the studies have been most robust, and we've used that information to take it towards other organ groups. As expected, we will be discussing a lot of off-label uses for several therapies. Although calcineurin inhibitors, or CNIs, have been successful in preventing acute solid organ transplant rejection, we are all too familiar with the numerous side effects and long-term complications. Progressive deterioration in renal function contributes greatly to increased mortality and morbidity. Calcineurin inhibitors have a narrow therapeutic index, and their use has been described as a significant contributing factor in acute and chronic allograft injury and ultimately graft loss, and leading to the development of the kidney safety net program for non-kidney transplant recipients. Additionally, for some additional information, by 10 years, all kidney allografts will have some sort of evidence of calcineurin-induced toxicity. And in some of the non-kidney transplant organs where we use the most or the highest doses of calcineurin inhibitors, the percentage of evidence of calcineurin inhibitor pathology in native kidneys is roughly 60 to 70%. Additionally, calcineurin inhibitors cause a lot of metabolic and cardiovascular complications associated strongly with hypertension, dyslipidemia, and new onset diabetes, along with multiple electrolyte derangements listed below. While some of the chronic side effects we can managed, some can be life-threatening. Those include thrombotic thrombocytopenic purpura, or TTP, where the formation of antiplatelet antibodies remain even after calcineurin inhibitor withdrawal. Additionally, posterior reversible encephalopathy syndrome, or PRES, where patients present with nondescript acute hypertension, headaches, seizures, encephalopathy, and visual disturbances, and this is diagnosed through neuroimaging, often lead to discontinuation, drug holidays, and reducing calcineurin inhibitor exposure. Occasionally, we do switch between classes, but oftentimes we need to consider alternatives. These strategies are not great, as elimination or lowering calcineurin inhibitor goals often put patients at risk for rejection and allograft dysfunction, leading providers looking for alternative forms of immunosuppression. One agent that has shown to be promising beyond its FDA-approved indication in kidney transplants is belatacept. With branded biologics, it is a recombinant soluble fusion protein developed by Bristol Myers Squibb and approved by the Federal Drug Administration in June of 2011 for the indication of prophylaxis of organ rejection in adult kidney and transplant recipients. Belatacept differs from other available maintenance immunosuppressive agents in terms of route of administration, since it can only be given intravenously and does not have the same mechanism of nephrotoxicity as calcineurin inhibitors do. It is a selective T-cell co-stimulation antagonist that binds to CD80 and CD86 receptors on the antigen-presenting cell. This in turn prevents the binding of the CD28 T-cell receptors, inhibiting cellular signaling, reducing cell division, and ultimately reducing cytokine release in response to antigen presentation. The enthusiasm for using belatacept came from promising retrospective experiences from large volume lung transplant centers where belatacept was used as a rescue therapy for patients where calcineurin inhibitors were either prohibiting or patients were experiencing rapidly progressive chronic kidney disease. As a reminder, chronic kidney disease remains one of the most common complications after lung transplant, where patients 5 years after transplant, more than 25% of them have a creatinine that is greater than 2.5 milligrams per deciliter. About 2.5 are on maintenance dialysis, and more than 1% require potential kidney transplant. Two of the major studies that have looked at utilizing belatacept as rescue therapy were done by Isella and colleagues at the University of Pittsburgh. 11 lung transplant recipients received belatacept during the study period with a mean follow-up of 136 days. 4 patients were changed to belatacept for thrombotic thrombocytopenic purpura, 3 for PRES, 2 for recurrent acute cellular rejection, 1 for CLAD, and only 1 was for renal sparing. Of these, 9 were not maintained of any calcineurin inhibitors for the analysis. At the end of the study, it was observed that there was a statistically significant increase in the mean glomerular filtration rate after belatacept conversion, and 4 patients that had a donor-specific antigen before belatacept, with only 1 continued to have it after treatment. In a different and then no patients had new de novo DSA, and the mean incidence of infections were comparable between groups. The other study, done by Timothy and colleagues at the University of Maryland, evaluated 8 patients who received belatacept because of acute or chronic renal insufficiency. Their mean glomerular filtration rate at the time of conversion was about 24. The glomerular filtration rate remained stable in 2 patients and actually increased in 5. Calcineurin inhibitor or enteric exposure were safely withheld or reduced without moderate or severe acute rejection during ongoing belatacept treatment. Well, and one thing to note, the average time of conversion to belatacept was between 2 to 3 years in this patient. This led to these promising findings shifted the focus to investigating whether there is a role for de novo belatacept or early conversion in the lung transplant group or population. When Huang and colleagues at the University of Washington and Houston Methodist attempted to incorporate belatacept in maintenance immunosuppression therapy, the results were discouraging. There was a randomized control study that randomized 27 patients who've all received thymoglobulin induction to either standard therapy with tacrolimus, mycophenolate, and prednisone, or tacrolimus, mycophenolate, and prednisone, where tacrolimus was replaced by belatacept 3 months after transplant. The study had to be stopped early due to 5 patients in the belatacept control arm died died compared to those in the control arm. An additional study that kind of mimicked the finding was done in France, which was a report which reported on 10 cases. This was done where 10 patients were converted to a calcineurin inhibitor-free regimen with belatacept, mycophenolate, and prednisone. The mean estimated glomerular filtration rate after starting belatacept significantly improved at 6 months after initiation and continued through follow-up, but the incidence of recurring and severe acute cellular rejection episodes were high in patients who were not on a calcineurin inhibitor. Chronic allograft dysfunction developed in 2 of the 9 patients, and the majority had to discontinue belatacept therapy. So all in all, both studies support avoidance of early conversion to a CNI-free belatacept-based immunosuppression in the lung transplant population due to high incidence of recurrent acute cellular rejection, including life-threatening episodes. Now, we're going to look at the evidence of using belatacept in the heart transplant population. This study was recently published by Oren and colleagues, where they used belatacept as an alternative therapy to immunosuppression for the management of highly sensitized patients or for renal sparing. Belatacept therapy, when combined with calcineurin inhibitor dose reduction, resulted in stabilization of renal function as measured through various renal surrogate markers. Patients on belatacept maintain a low rejection rate and preserve graft functions. Infections were common during the belatacept initiation therapy, which makes sense because you're adding a 4th agent to their immunosuppression regimen, which led to about 20% of discontinuation in patients. However, further randomized studies are needed to truly assess the safety and efficacy of belatacept in this patient population. All in all, I will start off by saying that there isn't a lot of evidence of using belatacept in the liver transplant population. The original study was pretty problematic, so I haven't even found the case report since. However, in the setting of contraindications to calcineurin inhibitors, belatacept can be considered in lung transplant patients. Typically, we have to be very careful with the clinical assessment and the risk-benefit ratio between the probability of improving calcineurin-induced side effects and the risk of rejection. An early conversion with a calcineurin inhibitor-free regimen should definitely be avoided. At Henry Ford, we've successfully transitioned 2 lung transplant patients to belatacept, but they were definitely more than 2 years or 3 years out from their transplant, and they tolerating the medication well. Same goes for the heart transplant recipients. When belatacept was combined with low calcineurin inhibitor dose reductions, this resulted in stabilization of the renal function and low rejection rate. However, we've seen an increase in the rate of infections. All in all, we need more clinical trials, and we need more good clinical trials that really show a difference in outcome for patients. and especially in the cardiothoracic population where typical advancements tend to be much slower to roll out. As I'm all sure we're all familiar with, one of the other major complications post-transplant is neutropenia. It impacts up to 50% of transplant recipients, and management is really a significant cost to the healthcare system and potentially to patients. It increases significantly the risk of bacterial and fungal infections, as well as rejection due to the need for reducing immunosuppression, most commonly the dosing of our antimetabolites. The differential diagnoses for neutropenia is quite broad. However, common causes include infection or medications, which we will review in more detail. Medications that we typically think of as causing neutropenia in our patients most often include the mycophenolate derivatives, Cellcept and Myfortic, anciclovir and its oral prodrug valganciclovir, azathioprine or Imuran, and two agents that we use for injection, thymoglobulin and Campath. Although the development of new medications in organ transplant, as Adina mentioned, is not common, there have been some increases in research regarding antivirals to help address some of the drawbacks of anciclovir use. So the prevention and treatment of CMV is not something I think is new to most of us here. It's actually described in the guidelines as a transplantation troll. It puts patients at risk of complications, graft loss, and comes with high morbidity and mortality if not treated timely. In healthy individuals, a robust innate and adaptive immune response restricts human CMV reactivation and replication. But in immunosuppressed patients, it's a little bit different. The CMV establishes latency in our CD3 progenitor cells. These latently infected endothelial cells are activated typically by an undefined stimulus and therefore follows viral replication. This is typically recognized by our immune response and mediated by T and B cells. In the context of immunosuppression, though, pre-existing T cell responses will be reduced because of the immunosuppression. In individuals who are CMV seropositive or have been exposed before, this leads to reduced control of cellular and clinical reactivation of this latent virus. In individuals who are seronegative experiencing primary infection and have no latent CMV in any of their cells, the major impact of immunosuppression is a reduction in the generation of these new T and B cells to fight off the infection. This ultimately reduces the ability to control viral replication and really can cause serious infections. Thus, we really want to make sure we're preventing during the highest risk period where the innate and adaptive immune systems are depleted. However, unfortunately, side effects and tolerability and medication access often limit the ability to maintain these preventive strategies during this time period. Valsite is the backbone of our prevention strategy. It is a prodrug, as I mentioned, which is rapidly hydrolyzed to the active drug anciclovir. The anciclovir is phosphorylated by the protein UL97 here in the picture. And then after phosphorylation, this complex helps to compete and it gets incorporated into the viral DNA, which prevents further replication of the virus. For each organ group, as I listed here, the length of prophylaxis really is dependent on the organ's overall risk or state of immunosuppression and the risk that CMV may cause in that patient. In all patients, though, Valsite is continued for at least 3 months after transplant, which really puts patients at risk of associated toxicities such as bone marrow suppression, namely neutropenia. So I'm sure we're all very familiar with neutropenia management as it happens a lot in patient and in clinic. It's really multifactorial and includes both assessing for possible causes and then adjusting likely offending agents based on the patient's risk factors as possible. So we're either holding the antimetabolite or Valsite if possible. In the event that neutropenia is severe, typically defined as an ANC less than 1,000, and holding meds either does not improve the neutrophil count or the offending medications can't be held, granulocyte colony stimulating factors such as filgrastim can be used to support the patient to decrease infection risk by stimulating the production, proliferation, and differentiation of neutrophils. This is the type of white blood cell that responds mainly to bacterial infections. While we generally think of these medications as being safe, the risk of rejection due to a stimulated immune system
by these agents was initially debated earlier in the literature and somewhat remains a little bit uncertain. Although they regulate the production of neutrophils mainly and the neutrophil progenitor cells, they have been shown to have minimal effects on the production or activity of other cell types. However, there have been cases of increased monocytes and lymphocytes in patients receiving filgrastim, which may increase the risk of transplant rejection due to the activation of the innate immune system. Studies conducted in renal or liver transplant patients demonstrated that most patients responded well to filgrastim and did not show an increased risk of rejection. And as most of us are familiar with their use in clinical practice, we do routinely use these agents based on existing data. Although they are effective, I'm sure most of us, especially in the outpatient world, recognize how many challenges are associated with these drugs. Authorization through insurance as outpatient is often extremely challenging, and it can be difficult to navigate if the patient's insurance will cover administration at home or in the clinic setting. Authorization through clinic is often not immediate. It can take up to 72 hours to get approval. And at home, access depends on the pharmacy stock, delivery to the patient's willingness to inject a sub-Q injection, which really can cause potentially long-lasting bone pain. And we see patients very hesitant to want to inject these therapies. We'd also be remiss, as we're going to talk throughout the rest of this presentation, if we didn't discuss the cost of the healthcare system as well. Each insurance company and healthcare system contract with manufacturers differently. And so certain products are often preferred over others. And it's also not easily accessible which ones are preferred over others. Not all products are also readily available in every healthcare system. So navigating this can also lead to significant therapy delays and prolonged neutropenia during this time. One way that costs associated with these drugs has been mitigated is through the introduction of biosimilars. A biosimilar is compared to and evaluated against a reference product, which in this case would be filgrastim, that is highly similar to it and has no clinically meaningful differences in terms of safety, potency, how pure the medication is from that initial reference product. The biosimilars are also approved through an extremely abbreviated pathway, so they don't have to go through a lot of the costly and lengthy clinical trials that we normally think of compared to the reference product. Filgrastim has several biosimilars, which I've listed here, including Neulasta, Neupogen, Zarzio, and Granex. And then although we kind of talk about them interchangeably on rounds or in clinic, these products are technically not interchangeable or substitutable per insurance regulations, but are clinically comparable. These allow for more treatment options, increased access to life-saving meds, and potentially lower healthcare costs through creating competition in the market. Studies have assessed the potential cost savings associated with these drugs. One study actually modeled the cost effectiveness gained from converting a group of patients from filgrastim to one of the biosimilar formulations. And savings from this conversion from the reference product to the biosimilar actually was upwards of $3 million to the healthcare system. At Henry Ford, we do have access to a lot of the biosimilar products, which helps provide patients with the products that their insurance will cover. And it may help to reduce costs of contracts for Henry Ford through competition with different manufacturers, which is one way we can combat the high cost of neutropenia. However, the savings may not be directly transferable or translatable to the patients, which we'll talk about in a little bit. So although neutropenia management has become an important part of care for our patients, it really would be ideal to find new agents that just don't cause neutropenia at all and potentially have reduced toxicity. So two alternatives that we may be familiar with are letermovir and maribavir that have been recently introduced to the market. Letermovir is the branded Preventative and works by inhibiting the CMV DNA terminase complex, which ultimately is required for viral DNA processing and packaging. Preventative was initially approved in 2017 for use in stem cell transplant patients, and then off-label use became a lot more popular over the recent years, and then most recently was actually approved in June of 2023 for prophylaxis of CMV disease, limited only to high-risk adult kidney transplant recipients after a very successful phase 3 trial. This randomized non-inferiority phase 3 trial looked at adult CMV seronegative kidney transplant recipients who received an organ from a seropositive patient. Participants were randomized to either letermovir or valsite. for up to 200 days after transplant. Letermovir was non-inferior to Valsite for prevention of CMV disease through week 52. And importantly, the rate of leukopenia or neutropenia through week 28 was statistically significantly lower with letermovir as compared to Valsite. So ultimately, we were able to conclude that in CMV seronegative kidney transplant recipients who had a seropositive donor, letermovir was proved non-inferior to Valsite for prophylaxis of disease and with the added bonus of lower rates of leukopenia. Of course, there's always limitations, most namely being cost. This is still a branded medication. It's extremely expensive for insurance companies to cover this medicine. Approval in other organ groups also limits insurance coverage significantly. Because the FDA approval is only in kidney transplant, it can be very challenging for us to get approval in other organ groups. The efficacy in other organ groups, especially higher risk like intestines or lungs, is not well reported. Of course, as pharmacists, we're also thinking about drug interactions, and letermovir definitely has some important ones to note. It interacts with tacrolimus and can increase up to 2.5-fold the concentration of tacrol when used with letermovir. And then alternatively, letermovir and azole antifungals. Letermovir can actually decrease the concentration of our azole antifungals by about half. And currently, the use of letermovir at Henry Ford is retrospectively being reviewed by our transplant pharmacist team. Because letermovir is only approved for prophylaxis, the need for treatment alternatives to Valsite also exists, which is where we get maribavir or the branded Liptensity. Its action is mediated by competitive inhibition of the protein kinase UL97, which results in the inhibition of CMV DNA replication and viral encapsulation. Interesting, maribavir was actually discovered by researchers at the University of Michigan and initially showed promise in phase 2 trials and was granted fast track status so that it was easily available, but it failed to meet study goals in a phase 3 trial. And the thought is that the lacking efficacy was due to the dosage used and that the patients may have actually been underdosed for it to be efficacious. Then comes the SOLSTICE trial, which is a phase 3 randomized controlled trial that reviewed the use of maribavir in refractory or resistant CMV. This is really a landmark trial for our patients as it reviewed maribavir versus investigator-assigned therapy. So this is basically comparing patients to whatever therapy the providers desired, typically either foscarnet or cidofovir. Also importantly, in our patients, this actually include all organ groups, which often doesn't happen in our transplant trials, and looked at both efficacy and safety outcomes. The results showed that significantly more patients in the maribavir group versus the assigned therapy group achieved the primary endpoint. Importantly, maribavir was also associated with less AKI versus foscarnet and less neutropenia versus Valsite and ganciclovir. Additionally, fewer patients discontinued treatment due to treatment-emergent adverse effects with maribavir compared to the investigator-assigned therapy. We were able to conclude that maribavir was superior to the comparison group for CMV viremia clearance and viremia clearance plus symptom control, and this was maintained post-therapy in our patients. Another disease state that is faced by a majority of patients post-transplant in all of our organ groups is the metabolic syndrome. Comorbidities like hypertension, diabetes, and dyslipidemia are chronic conditions we're left managing in our post-transplant clinic, or we are referring to other specialists. Dyslipidemia impacts anywhere from 30 to 80% of our patients and really can lead to increased cardiovascular risk through acceleration of atherosclerosis. There are many risk factors that exist, such as medications, lifestyle, diabetes, and genetics, just to name a few. Steroids alter lipoprotein metabolism via VLDL synthesis and downregulation of those LDL receptors. Cyclosporin and tacro interfere with the binding of LDL cholesterol to the receptor. And mTOR inhibitors cause hepatic synthesis of triglyceride, which increases secretion of VLDL and increases hypertriglyceridemia. Interventions for dyslipidemia has a significant impact on reducing cardiac death and non-fatal MIs in trials specific to our transplant population. And then an aggressive and common form of coronary atherosclerosis among heart transplant patients is cardiac allograft vasculopathy, or CAV, which occurs in up to 50% of patients during long-term follow-up. The risk also progressively increases after 5 years, resulting in an additional 10% increase every 2 years post-transplant. The pathogenesis is the result of adverse effects of humoral and cellular immunity on the artery wall and in combination with several non-immunologic factors such as dyslipidemia. Due to the concern for hepatotoxicity and risk of drug-drug interactions with immunosuppressive medicines via several different mechanisms, statins are prescribed often with caution in transplant patients, and outside providers are often reluctant to initiate them even when they're indicated. Fibrates also have limitations with drug interactions and limited use in the chronic kidney disease population, which really poses the need for additional agents. The PCSK9 inhibitors really represents this new class of lipid-lowering therapies that may be useful for our populations. They were FDA approved in 2015 as adjunct to diet alone or in combination with other therapies to treat adults with hyperlipidemia. These also offer an opportunity to decrease pill burden and improve adherence as they are biweekly injectable medications that are given at home. Very briefly, the molecule PCSK9 typically binds to the LDL receptor on the liver cell surface and then mediates degradation of the complex. When our PCSK9 inhibitors are involved, it binds to this complex and that degradation is inhibited, and therefore increased uptake of LDL cholesterol occurs due to the presence of more receptors at the cell surface. These medications have been studied and published in the solid organ transplant population, but of course with small sample sizes. The study published in JACC included heart, kidney, liver, and lung patients. And there was a statistically significant difference in LDL from a mean of 141 down to 57 with the use of this therapy. And most patients were actually already on one agent at baseline. This also included patients on different types of immunosuppression, and no new cases of CAV were noted in this trial. CAV has been described in the literature as the Achilles heel, really, of long-term survival post-cardiac transplant and has limited treatment options once it's developed. A systematic review included 6 studies of 97 patients and showed that these agents lowered LDL by an average of 82 from baseline. Serious adverse drug reactions were really rarely reported. This is well tolerated. And one study even reported outcomes on 33 patients with serial coronary angiography and intravascular ultrasound, or IVUS. And PCSK9 inhibitors were associated with stable coronary plaque thickness and lumen area. This class of medications is really shown to be safe, very well tolerated, significantly lowers LDL in our high-risk transplant patients, and also may attenuate CAV development. One of the ways we've been able to directly address the need for prompt and targeted dyslipidemia therapy in our patients is through our PharmD managed dyslipidemia clinic. We receive referrals or staff messages from providers to assist with management of dyslipidemia post-transplant in lieu of referring to another physician or PCP. Especially if our patients have really severe dyslipidemia diagnoses. This is often prompted by severe triglyceridemia in our patients on mTOR therapy. And we compared this to usual care, which was most often referral back to PCP management. Through the data collected and analyzed by our team, the approach resulted in statistically significantly reduced triglycerides by over 30% from baseline and achieved goal triglyceride levels in 90% of our cohort. This process also often led to quicker initiation of therapy, management of complex drug interactions, assistance with insurance auth and medication delivery, and follow-up on therapy initiation to ensure tolerability. We've also included a few PCSK9 inhibitor patients in this population who did well. We've probably now doubled the amount of patients that we follow in our clinic, and we've expanded to kidney transplant patients as well. This data was presented nationally at the American Transplant Congress meeting this year, and as an additional strategy we've implemented to combat challenges seen with the development of metabolic syndrome and to manage these high-risk patients more efficiently.
All right. Well, there have been advancements that aim to optimize transplant-related complications. The next layer of challenges revolve around insurance coverage. Can we actually get the therapy to our patients? We live in an era where insurance companies aim to dictate care through high out-of-pocket costs, excessive red tape in forms of prior authorizations and appeals, and that they have placed in efforts to avoid paying for high-cost therapies. This often leads to delays in access to care and oftentimes need for inpatient admission to administer high-cost medications such as IVIG or inhaled antibiotics and all these other therapies that insurance oftentimes refuse to cover, or and by having inpatient admissions, the reimbursement is often suboptimal. One of the fervent reasons for denial of outpatient therapies includes insurance companies really clinging on to non-FDA indications. So if they look into the drug cornucopia and they see that there isn't a transplant indication or a specific, let's say, lung transplant or heart transplant indication, they will not cover the medications. And oftentimes, the agents that we use are seen as standard of care amongst transplant providers. So, as pharmacists, we help bridge the gap often between standard of care and what we do in the clinics and in the inpatient settings, conveying that information and convincing insurance companies that this is something that they should cover. We have further broken down the challenges to access of care as either being cost prohibitive. As you know, our patient population is often underinsured or living off a fixed income. Thus, to combat some of the high out-of-pocket costs, we have helped patients enroll in manufacturer assistance programs, as well as various charity care and other programs through Pharmacy Advantage, where a lot of the times they're able to offer better costs and also promote reimbursement within our own health system. We have helped write appeals, tier exceptions, formulary additions to insurances that don't have the agents that we're looking to provide to patients, as well as to empower patients to negotiate fair costs for their therapy by calling their insurances directly. Mary Grace and I are involved in many of the pharmacy and therapeutics committees to help guide appropriate and safe use of many of our agents, like maribavir when it was approved for use, eculizumab, rituximab, IVIG, all these agents that we use for often treating rejection. And then we also provide pathways to assist with access to high-cost medication, both through our P&T committees, but also through national pharmacist-based work groups, where we work with transplant pharmacists from centers all over the country to help patients get access to medication. So one such example is oftentimes, let's say when there's a prior auth needed or an appeal, the insurance reviewers will look at micromedics or kind of like a basic drug compendium group. And if liver transplant, indication for liver transplant isn't there or something like that, they will not approve the medication. So for example, tacrolimus, although we use it in all of our organ groups, technically has an FDA approval just for kidney, liver, and heart. So we have worked kind of nationally to help update those drug compendium with our standard of practice, so patients have easier access to therapy and improved coverage. Here is a slide with the medications that have active patient assistance programs. There are quite a few, but these are still the medications that have that are branded. This is a manufacturer-sponsored patient assistance program where patients are approved based on qualifying income to help overcome the burden of out-of-pocket costs due to high copays. As Mary Grace mentioned earlier about biosimilars and their extensive use and kind of approval to market, there's been quite an influx of development of these biosimilar agents. As of January of 2024, the FDA approved 45 biosimilars across 14 unique biological molecules, and 38 of which have been launched in the United States. To the right, very small and hard to see. So I apologize about that. I've included some of the biosimilars that are available, and some of them, there are multiple biosimilars for the same product. One real life example is for tocilizumab. Henry Ford is moving towards using its biosimilar tocilizumab with BG, so oftentimes they have these like funky letters after the parent drug. And this change is expected to save the Detroit campus about $30,000 per year. However, one concern with the abundance of options is that pharmacy benefit managers are very quick to approve the biosimilars and to cover them, but it's hard to tell which one exactly they're going to cover. It's often either a guessing game or extensive work has to be done to figure out which formulation is covered. With that, we have to make sure that we supply it and it's orderable. So it involves quite a lot of work from our end and from the Epic builders and all the staff that we collaborate with in the in-basket messages of figuring out exactly what is covered. So additionally, although the biosimilars claim to be less expensive, there are a lot of hidden costs with the originator product, which is often overlooked. So what I found really interesting is that although the 2010 Biologics Price Competition Innovation Act really aimed to bring biosimilars to the market to increase the competition, reduce prices, improve access, when the American Journal or the Journal of American Medical Association actually reviewed the claims of that were processed for biologics compared to biosimilars for commercially insured patients over the course of 13 years, which is when the colony stimulating factors were first approved, patients had actually had an 8% higher out-of-pocket cost for the biosimilars rather than the reference products. And although the claims and even the study that Mary Grace referenced that looked at potential cost savings, when it came to the actual claims and the actual out-of-pocket expenses that patients pay, they tend to be higher. To add insult to injury, the Center for Medicare Services implemented a site neutrality policy in 2019, where it reduced the amount of reimbursement for certain services when conducted in more expensive health settings, so such as in the hospital or a hospital-based clinic. This is very problematic because hospital outpatient settings have higher level of care that we provide. So a lot of our patients have reactions and infusion reactions for which we have to be prepared. We have emergency services that are readily available through codes or a rapid response team. And these are expensive services that we have, and the standby capacity, and to have the standby capacity to infuse these agents safely is much needed, but we are essentially reimbursed less for providing higher quality of care. So this is a major setback, even in the setting of availability of biosimilars. But on a more positive note, the Henry Ford Health System has really shifted and emphasized its focus on precision medicine. And it has done so by adding a pharmacist to their pharmacogenomics team to evaluate various tests to ensure safety for our patients. While largely tested in the oncology group, we do have some transplant-specific tests that we have done, and we've done so successfully. So for starters, we have the TPMT enzyme for the metabolism of azathioprine, which although we don't use as often, it is important when starting a therapy, a patient on this therapy. Additionally, we have tested patients for various CYP3A4 or 3A5 enzyme mutations whenever there's to clarify clinical conundrums of absorption issues versus polymorphism situations where patients are fast metabolizers of everolimus or cyclosporin. So below is what the reports look like. And another positive note is the advancements in pharmacokinetic formulations. So posaconazole is a broad-spectrum triazole antifungal agent that is used both for prophylaxis as well as treatment of invasive fungal infections such as aspergillus and mucor. In the past, historically, it was only available in a suspension form, which had very highly variable absorption, leading to struggles to achieve therapeutic levels. Around 2015, and as it trickled down afterwards, there was revamp in the formulation, leading to a delayed release tablet that was developed, and it is actually absorbed in the small intestine, where there's not as much variation in pH in pH requirements. This has enhanced bioavailability and has led to posaconazole having great outcomes in non-inferiority trials compared to voriconazole, which, as we know, is very poorly tolerated in our patient population. So with that information, one example is that Mary Gace and I have helped incorporate that in our policies, use it and support the use of extended release posaconazole as an alternative to voriconazole. And although there have been some very exciting changing advancements in the management of solid organ transplant recipients, we hope to see more in the future. So we have some exciting trials that our patients are getting enrolled in that we're hoping to bring some new therapies to the market. This concludes our presentation, and we're happy to answer any questions.
Thank you, Adina and Mary Grace. If anybody has any questions.
Is maribavir included in the CMV resistance testing whenever we send that out? It is.
Yes, that's a good question. It is. It takes a long time to result, but it should report so that if valsite is resistant, then maribavir should, in theory, cover those resistance mechanisms. But if it's like foscarnet or cidofovir resistance, maribavir may not.
In regards to Repatha, is it used in conjunction with statins, or is it?
So it can be either. We commonly see it when we've done statins and fish oil and something else, and they can't take a fibrate or we need something. But there are some patients that I've started Repatha on as like the first line because there was a reason they couldn't take a statin. The only reason that would be harder is insurance approval. They may require you to try a statin first, but it absolutely can be used first line.
I apologize if you said this already.
That's okay.
Is Repatha first line for anything, or generally still like?
Not yet. I think probably just because it's new and expensive, but clinically it could be used first line.
Do you know who is like generally like starting Repatha, like PCP, cardiology, like who's using it the most right now?
I would be surprised if PCPs are. I know we do. And maybe cardiology clinic. I would imagine that they would because it's not that new of an agent. But we're typically getting referrals from liver and kidney patients whose were not managed by PCP or weren't sure how to be managed, and then we start them on the Repatha right away because we can use pharmacy advantage and get reimbursement as well.
Can you comment on these referrals you're getting from kidney? Like, what are the like which subset of patients are you getting like that you're starting PCSK9 inhibitors on?
Especially in kidneys, it's helpful because we can't use the fibrates, so they're like the perfect patients. I would say really anyone with hyperlipidemia, it's easier to send us a message and we'll manage them than hope the patient tells their PCP to look at the labs and manage. So we don't have strict referral criteria unless maybe they're already seeing endo or Henry Ford PCP internally where we wouldn't want to be dual managing. But as long as they have any hyperlipidemia or for our liver patients, hypertriglyceridemia on mTORs, we pretty much exclusively manage all of them.
Hey, Mary Grace. Nice talk by you guys. So I have a comment and a question. So my comment is that I absolutely agree with where even though something may be more expensive on paper, if the insurance companies actually pay for it, it actually may be cheaper for the patient, even though commercially it appears expensive. So I think there is some out-of-pocket costs we don't really appreciate as providers that patients have suffer too. That being said, so with letermovir, right, you probably know there's a decreased dosage with cyclosporin.
Yes.
So given the fact that you've seen the increased levels of tacrolimus with the standard dose of letermovir, does the company have any sort of indication to decrease the dose of letermovir for tacrolimus patients?
That is a great question. The company itself doesn't specifically say, but there's retrospective data of pharmacokinetic analysis that says it's anywhere, I think, between 30 and 50% of an AUC or concentration reduction. So we use this a lot in the lung transplant and kidney, but in the lung transplant patients who are also often on azoles, we will sometimes empirically reduce. They're just also higher risk from being much out of range. We're looking at that currently in rabivir because rabivir also has a drug interaction with tacro. And so we're looking back at all of our patients and assessing the changes in tacro so we can hopefully make a more standardized approach here at Henry Ford of if the dose should be decreased or if we just need to check levels in 3 to 5 days. Because a 30% decrease may not clinically mean much, but a 50 or 60% decrease could.
Yeah. So you'd be then not decreasing the letermovir, but decreasing the tacrolimus?
Correct. Yes. Letermovir will increase the concentration of tacro, but for the antifungals, letermovir can decrease exposure. So you might be under treating Mucor or Aspergillus. Yeah. Yeah.
This presentation, any these drugs should we be careful more with during renal replacement, during dialysis?
Oh, that's a good question. For letermovir and rabivir, there's no suggestions that we need to adjust the dose for renal replacement therapy. Repatha, I don't believe either. I don't think there's any else that we. Yeah, they really. Yeah, GC, like the filgrastims, definitely not. Which is the nice thing is we don't have to worry about. They can be used in dialysis patients. They can be used with bad kidney function. The only dose adjustment that Dr. Kim recommended is cyclosporin and letermovir. There's a dose adjustment required for letermovir in the setting of cyclosporin. Yeah. Yeah.
This may be for I was really fascinated by the precision medicine, right? And in our African American population, they seem to be rapid metabolizers of tacrolimus or CNIs. Have we done a lot of testing on our African American population to see whether or not
Thank you so much for this question. I've been waiting for the opportunity to talk about pharmacogenomics. So historically, we've done it very seldom. There's been times where we keep increasing doses of tacrolimus, we switch patients to Envarsus, and we don't see stable and consistent levels. I think we definitely can. Issues have been in the past with getting insurances to cover the testing. The response we've been told is, why do we need to check this if we can just increase the tax counts? So that has been where we've run into problems, into reimbursement problems. But we have done it in the past. And I think especially if there's a real concern, risk for possible rejection, need for biopsy in the setting of suboptimal tacrolimus levels, although we're making the necessary dose adjustments, we've taken out noncompliance and those types of things out of the equation. They do receive. In the heart population, we've done it a lot more, and that has helped guide some of the dosing, and especially because there's various degrees of mutations within the 385 versus 384, so that can also impact clinical care.
Yeah, I think that, I don't know, from a research perspective, since Henry Ford is so big on precision medicine, you could just even get like a feasibility or pilot study on a cohort patient, just to see, what happens, and you can take those data for the insurance stuff.
Yeah, I think that would be our hope. I think somehow through our pharmacogenomics group that exists right now, because we have done it on a couple patients that were inpatient and we were able to do it. So obviously long-term outpatient would be different, but I think that would be great because if we can prove that starting someone earlier on a higher dose that we would otherwise be afraid to do because of their polymorphism would be really helpful, or early conversion to Envarsus.
Yeah, when I was a resident, one of the most interesting cases was a patient received a liver transplant, and the CYP enzymes of the transplanted liver, the patient was a very slow metabolizer. So we had very consistently super therapeutic tacrolimus levels with small doses. So we ended up finding out that they were very poor metabolizers. So it's another interesting part where genomics come in.
I don't see any questions. Sorry, go ahead.
Just for that one that you were mentioning, so the person was actually African American, but the liver they got
Was
white, maybe?
yeah, but
And a
essentially
low-
the donor was a very slow metabolizer of tacrolimus, and we were having a really hard time dose adjusting in the setting of not knowing what else was going on. So we did
Huh.
some genomic testing, and we found out they were slow metabolizers.
Any questions from the online audience? I don't see anything in the chat. I have one quick question. I was very surprised to see the belatacept data in the non-renal transplant patients. So as you know, we have patients on 4-drug regimens with slightly lower dose of FK up until 1 year. We haven't seen such a huge risk of infections or death. So I'm wondering, can that data be extrapolated to non-renal transplants, and so we can preserve renal function and have less need for dual organ transplants down the line, and so we could have more renal preservation down the line.
I think that's a great point, but I think in the lung transplant population where the risk for infection is so much higher, that adding a fourth agent is difficult. But I think in the heart transplant population where we've seen improved rates of ESA clearance and stable renal function, that can
And livers, I've seen. So there was a risk of PTLD, and I know several centers now are not taking into account even EBV mismatches, and people are using belatacept even in EBV mismatches, and not develop that much of EBV. Are we here in Henry Ford? I know we are screening everybody there in Henry Ford where we could start using Bella, and I think that has been one of the biggest concerns with the liver population in our SLKs. So your thoughts on that?
And I think people are scared to do it, so no one's published on it, which I think is the challenge. The initial liver trials were very bad, but that I think was 2013, 2014. There's a couple, I think we discussed for patient, there's a couple case reports on a liver after kidney where they converted to Bella and it was okay. But you're right, the increases in PTLD is no different than the risk we see in Tacro. The cases in the benefit studies were quite small. So I don't know that that's a true risk. I think they just need to further labeling the package. So I don't know that it's a bad idea on the right patient. I think we just won't have as much literature to support it until I guess we publish our 2 case reports.
But at least we have a start.
Yeah.
I think the dosing strategies and the tacrolimus tapering for the times that we have used them.
Yeah.
So just choosing the right patient.
Thank you.